let's get into a case. So these are cases that questions that you would get on your boards. So you have a 24-year-old female with SS disease that is coming in with an acute vaso-occlusive crisis. She has 10 out of 10 pain in her back and legs, but no respiratory abdominal symptoms. She has a vaso-occlusive crisis every 2 months and gets transfused for symptomatic anemia 1 to 3 times per year. Her medications are folic acid and hydroxyurea. Her vitals are within normal limits. Her temperature is just mildly elevated at 99. Her O2 saturation is 96% over room air. On exam, she has scleroicterus and a grade 2 out of 6 early systolic murmur. Her lungs are clear. She has no hepatosplenomegaly or tenderness. Her hemoglobin is 7. Her MCV is 110. Her creatinine is 0.4. Her chest x-ray is normal, so you treat her with hydration and incentive spirometry. So which is the following analgesic regimen is the most appropriate for this patient? Would you treat her with as-needed ketorolac or morphine? Would you treat her with as-needed morphine? Would you treat her with scheduled pyridine? Or would you put her on scheduled morphine? So this question is trying to figure out what is the appropriate pain management for a patient with sickle cell disease that's coming in for an acute vaso-occlusive crisis. And the answer here is D. And the reason for that, MixLab is trying to teach you that during hospitalizations for acute vaso-occlusive crisis, the most effective opioid analgesic regimen is regular scheduled opioids or by PCA. So you can do scheduled injection or pills or whatever it is that you decide, or you can just go straight to a PCA pump rather than using as needed regimen and getting behind on the pain. So that will shorten their stay if you can actually get ahead of their pain and treat them on a scheduled basis. Next question, you have a 24-year-old that's at 12 weeks gestation with SS disease that's coming in for a routine visit. She's had multiple uncomplicated pain crises at home, and she treats them with hydration, non-opioid analgesia, and incentive spirometry. She requires hospitalization for pain maybe twice a year. She's declined use of any hydroxyurea. Her other medication is folic acid. Her vitals are normal, and her exam is remarkable for mild scleroicterus and a 2 out of 6 early systolic flow murmur. Her hemoglobin is 7.5. So the question here is, what is the most appropriate management? So what do? She's pregnant, and her hemoglobin is 7.5. Do you give her a blood transfusion to get her to 10? Do you give her erythrostimulating agent like darbepoetin or Procrit or one of these other injections to get it up? Do you exchange transfusion, or you just don't transfuse her at all? So the pearl here is, do not transfuse a patient that doesn't need it. So for uncomplicated pregnancies, the recommendation is not to transfuse because it does not improve mortality or morbidity, but it sometimes actually can improve pain. But in a randomized study, they showed no mortality or morbidity benefit. And here you see other indications where you should transfuse, so things like stroke and acute chest and those things like that. All right.